Sí. Stefan, I'm going to have maybe my colleague here, Dr. Paredes, make a brief introduction, and then I will expand that introduction.
Very good.
Hello, thank you. Thank you, doctor, for being here. And well, we will start this meeting. Hello, everyone. We will start one session of a structural program here in Tech Salud. And well, it's a great pleasure for me introduce an amazing cardiologist, professor professor in medicine, Dr. Stefan Anker, that is an PI of so many clinical trials. And well, today we'll start with a meeting that will analyze the three principal clinical trials about mitral regurgitation and transcatheter therapies that we... okay.
Thank you, Pepe. Stefan, thank you for being here today. This is the first lecture of a series of lectures that we at Tech Salud have initiated, and a program that we call Master Class in Structural Heart Disease. So, Stefan, you're the first master professor of this lecture. But I think we look forward to this conversation. We look forward to have you here in Monterey at some point in the future. Yeah. We were trying to arrange and coordinate with Chicago, but I know it's hard, it's difficult, but maybe if it's not later this year, maybe we'll do it next year.
Of course.
And for the rest of the audience, I think that Stefan has had a terrific career. He's been a cardiology investigator. He and I have worked together in many projects in the past, and has become a very prominent clinical investigator in the field of heart failure, advanced therapeutics, and most recently in many aspects of interventional cardiology. So, Stefan, thanks for being here. I really personally appreciate it, and we're looking forward to your conversation.
No, thank you so much.
The floor is yours.
Thank you. Thank you so much, Guillermo. And what everybody should also know as a background, there is some family ties also. My son spent some Thanksgiving time together with Guillermo's family, and even in Mexico, I think, with some giant butterflies and things like that. I think with some little trouble getting back into the US also, but I think your wife, Guillermo, thankfully sorted that one out. So it's a great pleasure to really now share with you some slides and some knowledge about functional MR and its management using MTR therapy, really. And this is mostly an update of the trial evidence and mostly concerned to the RESHAPE HF2 trial. Now, of course, you all know that valvular heart disease, and particularly then functional MR and TR, are some comorbidities of many in heart failure that need really solutions. And I think over the time with the devices that were developed in different kind of commercial entities over the last 20 years, really there are some good solutions, and the MitraClip in its several generations is a therapy that I'm speaking mainly about that has some real good evidence. Now, when we are applying this therapy, there is the aim to really kind of improve the outcomes for patients with regards to hospitalization, with regards to symptoms and New York Heart functional class. And I will show you all of this for our trials. This is the current guideline recommendation status. You basically give the foundational therapy. So a good trial should also have, of course, these therapies on board. And then we are targeting the different kind of phenotypes of heart failure patients to really specifically address them. Before our study, after COAPT and MITRA FR, mitral regurg being targeted with MTR therapy had a class 2 recommendation. Let's see whether in the near future this can be different. So what, first of all, was the evidence before really we went into the final stages of our trial? I don't want to say before our trial, because our trial actually, as you will see in a second, started quite a long time ago when these other trials were still ongoing. So the MITRA FR trial published in 2018 at the ESC Congress presented, focusing in the initial presentation at the 1-year outcomes, had a very neutral result. Death from any cause or unplanned hospitalization for heart failure, you can see here, no difference. I would like to highlight already something about the different trials being different in several aspects, but particularly with regards to prognosis. 23% mortality at 12 months in both groups together. Now, our trial, the COAPT trial, focused on 2 years of follow-up. There is 2-year data available for MITRA FR. It didn't make any difference, equally very neutral. And then, of course, there's the COAPT trial, and I start showing a few slides about COAPT. Some of you, of course, may know all of this, but maybe with slightly different emphasis. The age of the patient, about 72, 65% men, about 35% diabetics. Here you see atrial fibrillation, about 55% of the patients. GFR on average about 50, NT-BNP, and remember this number, if you take these two groups together, about 5,500 is the mean value at baseline. If you then, I hope, Gamo, you hear me well and without echo and these things. Is that okay?
Yes.
Okay, good. All right. So basically, you then see here beta blocker therapy 90%, RASI therapy, however, only 65%, in 50% had MRAs, diuretics about 90%. Just keep these numbers a little bit in mind when I show you some more. Ischemic etiology, 60%, a defibrillator, about 30% of the patient. Now, a big difference, then I can say this already, to RESHAPE is the ERA, and actually that's also a big difference to the MITRA FR trial. You can see here the ERA on average about 40, so 0.40, and the end systolic and diastolic dimensions are giving here. Not very much enlarged ventricles, but the ERA is rather bad. Ejection fraction, 31%. So these patients were included in COAPT. And then you see here the overall mortality result, a 38% reduction. But interestingly, the mortality rate in COAPT was also 23% at 12 months in the control group that you can compare. So really, you might say from a mortality standpoint, the severity was similar. Of course, from other standpoints, it wasn't. But overall, mortality is a very good characteristic. Now, what many people have forgotten, that the primary endpoint of the COAPT trial was actually this one here, heart failure hospitalizations as a total number of events accumulating over 2 years. And you can see here, there was a 47% reduction in the COAPT trial. This was the primary endpoint. You can see here the list of endpoints. And please remember only not necessarily that of all these endpoints, they worked out and they were significantly positive, but we kind of modeled in what I'm telling you then in a second about RESHAPE. We modeled our outcome assessments in the end to what COAPT also did, to really have as representative and additional information as possible to this previous kind of investigation. Now, coming to the RESHAPE HF2 trial. Now, the first little comment is, do you actually know why this is called RESHAPE HF2? What about RESHAPE HF1? You might argue never published. Well, that is true. Originally in 2013-14, the RESHAPE HF1 trial, with the PI being Piotr Ponitkowski, was initiated. I was a member of the steering committee, but I wasn't in charge. And we tried to really recruit very similar patients as in the end were recruited in RESHAPE HF2, but it didn't work out. HF1 focused on Germany, the Netherlands, and Switzerland. It focused on countries where the device was already approved and reimbursed. And the hope was that people would randomize, but they didn't randomize, they just treated. And so they didn't want to randomize. So in the end, after 2 years and only 42 patients recruited, RESHAPE HF1 was essentially stopped. Piotr was asked, well, do you have any ideas? We went to Abbott and asked them, well, let's do an investigator-initiated trial where we do the reverse from what you're saying. Before, we are now only recruiting in countries more or less where it is not approved except for Germany. So focusing on, for instance, Poland and Greece, and to some degree Czech and Denmark, Italy, Portugal, Spain and the UK we included. But you can see here on the right the numbers. Mostly this was done 80% in Poland and in Greece. Basically, Piotr asked me to run the show through Germany, so we are together chairing the trial. You see here all the people involved, quite a big number of very good people. The legal sponsor was the University Göttingen. The financial support came from Abbott, but everything else was investigator-initiated, and Abbott stayed out of the practical issues in this trial. In the end, we recruited in 9 countries 505 patients. The trial was 1-to-1 randomized. First patient, first visit, we are talking March 2015. Last patient, first visit, so the end of the recruitment was in October 23, end of follow-up was April 24, database lock in June 24, and then last year, end of August, we presented this at the ESC Congress. The patients we aimed to include were symptomatic patients, ejection fraction 20 to 50, heart failure patients, and they had to have +3 or +4 functional MR by echo core lab. That is not an inclusion by EROA. And I was saying this already because our numbers are lower. It's a 3+, 4+ assessment by echo core lab. Stefan von Badeleben, he was many years the editor-in-chief of the Euro Echo journal, knew what he was doing. Basically, these patients had also prior hospitalizations or raised natriuretic peptide levels, and they had to be suitable for a mitral clip procedure, 1-to-1 randomization. And you can see here already that for the main outcomes, we had a 2-year follow-up, but the all-cause mortality, then we had on average 3.5-year kind of follow-up with 8 years maximum follow-up. Why was the main outcome restricted to the 2 years? Because that was the original design. That was what the patients consented for, and it was simply impossible in the middle of the trial to reconsent patients, and many had already, of course, also passed away or finished the trial. And so we were restricted to the 2 years because of the adjudication of the results. The original primary endpoint was recurrent events of cardiovascular death and heart failure hospitalizations. Now, of course, we reconsidered this in light of COAPT, in light of everything else. And basically we said, okay, let's keep our original primary endpoint, but let's have in addition recurrent events of heart failure hospitalization, like the COAPT trial as the primary endpoint, and then also Kansas City cardiomyopathy questionnaire. And we used something called the Hochberg procedure. And if this is a masterclass kind of presentation, then maybe the teaching kind of thing is it's not necessarily to only have one primary endpoint. You can have more than one primary endpoint. You just need to statistically adjust for that. How does it work? Well, basically, you still use the alpha 0.05 as is customary. And if all 3 of them are below 0.05, okay, you won, fine. But if only 2 of them are below 0.025, you also won. And if 1 of them is below 0.0167, so 0.05 divided by 3, then you also won. The beauty is you don't need to pre-specify which of the endpoints is winning how strongly. And typically, when you design a trial with one primary endpoint, and now want to change for this one primary endpoint, the alpha you test to from 0.05 to 0.0167, you only need to increase the number of patients by 15%. But by doing so, essentially you get 3 chances of winning. So from a trial efficiency perspective, this is much more efficient. We have actually published recently about this, also a specific paper in a new journal called Global Cardiology. So the current primary endpoint, at this time, we were not very convinced that we might win on it simply because of the cardiovascular mortality aspect. The recurrent heart failure hospitalization was we were more convinced that this could win. The primary endpoint in COAPT was that, so we wanted to match this. And KCCQ, well, Triluminate showed us recently that KCCQ alone can get you actually even regulatory recognition. So we added this. Has this been done before? Is there some general kind of advice on these things? Absolutely. There's even an FDA guidance on this. Very interesting kind of reading. We have available different statistical techniques. Bonferroni adjustment is really rather inefficient. One way of doing it is the Holm procedure, but the most efficient is the Hochberg procedure. And indeed, that has been done before in the Miracle trial. And by the way, also the Deliver trial, very recent trial, has had more than one primary endpoint. Of course, both were successful, so people don't really realize that there were several primary endpoints, but Deliver had actually also 2 primary endpoints. The Miracle trial presented in the New England Journal many years back in 2002. They effectively used this procedure. Look here at how they describe the p-values. It wasn't called in the paper like this, but this is the Hochberg procedure, the way that the Miracle trial used it. So as a very practical example, you take your p-values, you sort your p-values, and now if basically you see all 3 are below 0.05, you won. If the highest p-value is above 0.05 and the second highest is above 0.025, you can still win if one of them is 0.01. And here you can see an example where you win with 2 such endpoints. And at the beginning, we thought this might not be too unrealistic for RESHAPE, thinking that our original endpoint was a little bit underpowered. Now, of course, you may know the results already. This in the end wasn't that important, but as a teaching kind of example, it's very useful. If you ever are interested in publishing in the New England Journal, if you have 3 primary endpoints, there's another little extra bonus. You are guaranteed to be allowed to report all 3 p-values, regardless of whether one of them is non-significant or not. That's a technical advantage as well. So in the end, we had the Hochberg procedure for these 3 primary endpoints. Actually, in the secondary endpoints, we had 5 of them in parallel. And also for 5, you can use the Hochberg procedure. You basically 0.05 divided by 2, by 3, by 4, by 5. This is something that you can do. And we have done this in this paper as well. I will show you the consequence of this in a few minutes. Now, this is an interesting graph. It shows the recruitment per month in our trial. And look here, there is a big gap. Now, what happened in these special lectures where you have a little bit more time, you can also talk a little bit about problems. The trial originally had 430 patients planned, and we reached this in the middle of 2019. And we really knew, looking at the data, that we were underpowered at the time because of what is called over-dispersion. There was basically too much abnormality in the distribution of events seen in a blinded assessment. So we thought we need to have more patients. We negotiated with Abbott a new grant. Then also came the COVID time. So essentially, we were able to restart the recruitment only in mid-21. And then you can see towards the end, we finished this. In the end, we finished at 505 patients. I think this was a good achievement. So here are the characteristics of what we recruited in terms of a population in RESHAPE. You already see 70 years of age and about 20% women. Diabetes, 35%, pretty much the same as in COAPT. Symptomatic patients here, you see 48% atrial fibrillation, COAPT 5% very similar, also GFR, maybe a little less. We have 55, COAPT had 50. Treatment was even higher in terms of percentages. Here you see more than 80% MRAs, 50% in COAPT. We had 82% overall for RASI therapy. Some patients even had SGLT2s, beta blocker, 95%. So well-treated patients, very well-treated patients indeed. In terms of other characteristics, for instance, here the KCCQ, a very poor quality of life of these patients. In order to be willing to undergo such a procedure, I think there needs to be some higher degree of burden to the patient. But if you then, for instance, take the median anti-BNP values here, about 2,700, if you are more thinking in terms of BNP, then 500 approximately was the median BNP for the whole population. Ejection fraction, 31%. You heard these numbers before, but then look at the ERA, 0.23. Very different than other trials. Stage 3+ and 4+, about half of these patients each. And so this is the comparison between the trials. RESHAPE, COAPT, MITRA FR, similar age, by and large, similar GFR, ejection fraction spot on the same, similar 6-minute walk test distance, but very different ERA, very different natriuretic peptide levels. And basically, if you then look here at the distribution of the ERA, you can basically see COAPT distribution here, MITRA FR somewhere in between, RESHAPE with the least number of patients with very high ERAs. So you might argue there is a difference. I should also emphasize that really, strictly speaking, 3+ and 4+ are not ERA-based classifications, certainly not in Europe, but still, of course, many people think like this. Well, our trial, as we can discuss in the end, may challenge some of these kind of thinking approach. So RESHAPE is very different in terms of the positioning. If you take the ERA on the one hand, and if you take the left ventricular end diastolic volume, then basically we are similar to COAPT. In terms of the volume, we are much less than MITRA FR, both these trials. So maybe in the end, it's not the ERA that guides the success chance, but the left ventricular end diastolic volume more than anything is guiding this. Of course, you know already that RESHAPE worked out. So we then basically followed the patients. We implanted the devices in 98% successful. There were also during follow-up, some unplanned empty additional procedures in the treatment group, but only 8. And there were additional unplanned empty procedures in the control group. This is something that you have to live with. That, of course, may reduce the chance of seeing a difference if then also the patients in the control group get treated. I can tell you already that regardless of whether you consider or don't consider these additional MTIA events as events of hospitalization for heart failure, that the results remain significant positive. And these are these positive results overall for the first 2 primary endpoints. So if you take the heart failure hospitalization plus cardiovascular death, 36% reduction, p-value 0.002. If you take only the recurrent heart failure hospitalizations, a 41% reduction, and also for this 0.002 p-value. So really positive results for the first 2 primary endpoints. And the KCCQ score, overall summary score, an 11-point difference, highly significant result. Really very fast, you can see a big difference. And I guess that's expected. Over time, there is a little bit of an attenuation of the difference. But don't forget, also some patients now got treated in the control group. Subgroups, look at the points all to the left of the equalizer line. If we focus on a few things, the MR grade, well, there was a trend that the patients with the more higher grade had a little bit of a bigger benefit. But for instance, left ventricular end diastolic volume and ERA show in our trial no significant interaction. So this treatment works. Hospitalizations before, that made the difference in our trial, quite a big one. So if you had a hospitalization, then the benefit was much bigger. But overall, you can see a very similar result. Now, secondary endpoints, remember, all 5 of them were combined by the Hochberg procedure. That means, and you see here that 2 of them are very, very significant, the mitral regurg and the New York Heart Function Class assessment. Then, of course, the rate of death was neutral, 10% reduction overall, and recurrent hospitalization for any cause, you can basically see an 18% reduction, but not significant. So what about the 6-minute walk test distance? There was a 20.5-meter difference, a p-value of 0.05, but technically that is not significant because we should have achieved 0.0167. This is a consequence of the Hochberg procedure, but we didn't have to specify an order. All these 5 tests were tested at the same time with an alpha protection because the 3 primary endpoints worked out. So the alpha was preserved and was used for the secondary endpoints. So neutral results for mortality. Some more data on this. You can see a cardiovascular death. You can see a non-cardiovascular death. Please ignore this significant p-value here. Of course, there is no rational reason why non-cardiovascular death should be reduced. That's a chance finding. Here's the data for the MR severity. By the way, we had a second paper, and that is in much more detail published in the JAG paper, where Piotr Panikowski is the first author. In blue, those with the 3+ at baseline. In red, those with the 4+. And you can see here that by the end of the procedure, 70 to 80% of the patients had 1+ or better mitral regurg status. So the treatment actually really worked. New York Heart Class over time, again, particularly significant in the beginning. At the end, when some more patients got actually either treated also in the control group or alternatively left the sample because they died. So basically those that stay alive or have somewhat better status, but particularly in the beginning, you have a very highly significant symptomatic difference here. You can see this also showing the data separately for improvements and deteriorations of New York Heart Class, both significant. So you prevent deterioration and also you trigger improvement of New York Heart Class. A little bit more data on mortality. You see here we had an average follow-up of 38 months for mortality, which was longer than for the other events because death is a public event in Europe, and anybody dying, you can find out whether or not they are dead. So overall, the rate ratio was 0.90. And for comparison here, we had 1,600 patient years of follow-up. Originally, COAPT had 860. So quite a powerful piece of information. But the number of events we had was less. Interestingly, at 5-year follow-up, restricting it, taking out up to 8 years, actually 19% reduction, 0.11. At 2 years, even a 27% reduction of mortality, 0.09. So the longer the trial runs, there is some degree of equalizing. Let's see whether we will see this in future in a more different results. There's another way of arguing. Those with 2 years of follow-up are mostly the patients that were kind of randomized after 21, 22. And in this time, we use the most recent version of the MitraClip. So at some stage, we will also be able to tell you things about the different generations of MitraClip used. We used actually in the trial all the generations, 4 generations. And so we will in the future have some very interesting information there. Basically, what else is happening? You see, I spoke already about the unplanned implantations and other kind of interventions here and the mitral valve surgery. You can see all of this, but safety events, otherwise no problem, no difference. Stroke here, for instance, 5 and 2, and heart transplants 1 and 0, ICD, CRT implantation in both groups 7. Now, in terms of the sensitivity analysis, when you are basically taking out the M-tier patients, so if you got an unplanned M-tier after baseline, then you are excluded, and you can see still significant results also down here in the most conservative way of analyzing the whole trial. So in summary for the trial, first of all, we have quite a big success for the rate of heart failure hospitalization, CV deaths for heart failure hospitalizations alone and KCCQ. All of this really highly significant, and symptoms and walking test, also worked. This is published in the New England Journal. The second paper is published in JACC. So this you can all read in more detail. What you will find there is then, for instance, also cardiovascular hospitalizations. You see here significant reduced hospitalizations for any cause, well, 18% reduced. These, of course, it's a therapy of the mitral valve, and cardiovascular hospitalization are part of any hospitalizations, but in total, you don't change that significantly. And here you see that, of course, the patients also have repeat events. Just for information, you, of course, also reduce recurrent events. Now, this graph is a bit complicated, but essentially it says that you reduce the time spent in hospital. You increase the days alive and out of hospital from 686 to 729 days. In other words, the patients in the treatment group were 1.5 months more alive and out of the hospital. So that is valuable information as well. What were the predictors of hospitalizations? And apart from a poor quality of life and prior hospitalization, also the fact whether or not you received the device was a predictor confirming that this is a useful thing to do. And then hospitalization death time to first event analysis. You can see here also that time to first events showed some very good results. Now, I showed you results and coming to an end for 3 trials. So obviously you may want to do a meta-analysis. And this meta-analysis based on all the data that is published, with a very tiny addition where the French colleagues gave some additional information. Then Marcus Anker, my son, published this in JACC last year. And if you look here at hospitalizations for heart failure within 24 months, you can see overall a 37% reduction with quite some degree of heterogeneity. You see, of course, that the MITRA FR results are different. That's also true for the composite of death of first hospitalization for heart failure. Again, overall significant and a 28% reduction, but really quite a difference also for the result of MITRA FR to the other 2 trials. And lastly, death from any cause over 2 years. You can see a 24% reduction, p-value 0.056. And again, heterogeneity, meaning that MITRA FR is different. People have even argued we shouldn't even include MITRA FR in these analyses. I don't think that's correct. It's the totality of evidence that counts. Maybe we can beat these results with the individual patient data meta-analysis that is hopefully coming in a year or so. Let me basically personally conclude that MT is indicated for patients with symptomatic heart failure and a severe functional MR. It improves heart outcomes and quality of life and exercise capacity. Now, a broader application of MT for patients with functional MR and less than severe disease grade may be appropriate, but I think that deserves future further study. I think in order to look at this, if we talk about severe mitral regurg, this can become now a blue rectangle in terms of severe functional MR. I think we have shown that this should be a class 1 recommendation. For the less than severe functional MR, I think we need some more information. So thank you so much for all your attention, and I'm really looking forward to the discussion as much as you like.
Thank you, Stefan. So let's just open for some questions from the audience. If not, I'll ask you a few.
Well, thank you for an amazing presentation. And when I want to make a question about the feeling of the future, you say it maybe at the end of the presentation, but the feeling for mitral H2H repair will be trying to perform the procedures early in the disease, or should be addressed by different paraclinical aspects as CMR or specific points at echocardiography. I don't know what about your thoughts about it.
Well, I definitely think that we should address functional MR that is severe. We should definitely address also patients that have less than severe functional MR if they had hospitalizations for heart failure and are essentially qualifying themselves as in need. And the best time point is then when the ventricle is not too big yet. It seems that very large ventricles with very high volumes, like in MITRA FR, very large diameters, they are then a little bit less the ideal candidate. So anybody with severe functional MR, when you see them, is a good candidate, but the earlier you catch them, the better. And those with less than severe, particularly those that have hospitalizations, are then your preferred candidates, I think.
So, Stefan, I have two separate questions that are maybe somewhat related. And one is the time of assessment of the severity of MR is really quite important. And I think that with the ease of these interventions, with the availability, the question is, what is the role of a good cardiac heart failure evaluation before? Like in most of these patients done in Europe, they're probably seen in a comprehensive manner. But we're not in the US, but the Mexican private environment is very similar to the US. And once devices are available, I think there is an impetus and a drive to perform interventions. So I say, how do you control for that? And how do you measure the optimal timing? What recommendations would you have to the evaluation of the severity of MR?
Well, what shall I say? We are using the European guidance on 3+ and 4+, and it's a comprehensive assessment, not only taking into account 2D echo data with some cutoffs for EROA. It basically is looking at the moving pictures. And so, first of all, this is a call for experienced echocardiographers that are able to really make these assessments. And if you start a new big program, I think it's worthwhile to have your echoes, the first 10 or 20 echoes, qualified by an experienced core lab, just to get some second opinions on this. And if that is not of interest, Stefan von Bardeleben, he was the core lab head in our trial. He is now taking on a 50% position in Montreal. That means he's on essentially the same time zone as you. So he has a core lab in Germany that we used, but he also now has a core lab in Montreal. And if you set up a new program and you're uncertain about the way to qualify really the right patients for this, I think having the first 20 or so echoes overread by somebody who can, from the echo picture, and Stefan is one of the most super experienced interventionalists and equally a super specialist in echo. Very few times you have this kind of combination. He can really tell you from the echo what possibly is a good idea to do. But of course, if you take COAPT-like patients, then there's no question, do it. But the second you want to go earlier, I think it is worthwhile to exchange opinions with these kind of experienced people, or basically try to emulate what we have in terms of the average results for the echo in RESHAPE.
And one additional question, and that is in patients that have more preserved EF and less severity of MR, less dilation, that may have valves that are suitable for repair. What do you see the future of good surgical repair intervention versus percutaneous procedures? How do you see this? Do you think that surgery in good hands with repair, it's death? Or is the possibility of performing surgery in these patients where there is a potential of positive remodeling may potentially be a suitable alternative? How do you see the field?
Whoever can be clipped should be clipped. I mean,
I'm sorry.
I said, whenever there is a possibility of clipping, in our place, there is a general recommendation: clip. Surgery is for those cases that absolutely cannot be clipped anymore. Maybe they're too far gone. Maybe there is a patient preference for some reason against it. I don't know. But if there is an opportunity for M-tier, it would, by and large, 95% or more always be the priority to clip.
Mm-hmm. Okay, so any other question or
another question of the audience?
There are new devices coming up, Stefan, that will make the intervention even easier, faster, fewer complications.
Well, there is
less dependent on the echocardiographer.
Well, my understanding, of course, is that the mitral clip specifically with the newest generation has become much easier to use. Don't forget, I'm not a personally interventional cardiologist, but so this is secondhand comments with some kind of the devices in themselves having been created in a way that they're easier to handle and the valves are easier to grasp. But there is, of course, the Edwards approach, Pascal. There is also the Carillon device. So there is other devices that are used. And the Carillon particularly is, of course, in many ways easier because you don't need kind of echocardiography, TE, you don't need the transesophageal echo. And many people may perceive it to have a much shorter kind of learning curve. But on the other hand, you need to reserve it for the right cases. But yeah, with the Carillon device, there's one advantage, apart from being easier, you can still do a clip afterwards if still necessary. Whereas with the clip first, Carillon second is not so much possible.
I guess one final question before you leave to go to dinner.
Okay.
I'm curious to see if the course of atrial fibrillation that may be a predisposing condition for heart failure hospitalization is lessened, is the AFib burden decrease, or if the strategy for pharmacological or interventional therapies make it easier, more suitable. Has anybody looked at that into this population?
Very timely question. Unfortunately not. I mean, AF burden would really need event recorders if you want to truly assess it. We are kind of having a mountain of additional questions that hopefully we can answer in the next 1 or 2 years. At this time, I'm afraid I've more or less shown you what I have. Shall we say, this is the longest, most comprehensive talk I had the chance of giving you on the subject. That's why I think, you remember my SMS said 20 or 30 minutes and the answer was 40 minutes. So this is really at this, in terms of what I can show in terms of new data, good data, is the extent of it. We are working on some more things hopefully soon.
Very good. So you'll come in person next time, and then we'll spend even more time.
Yes, and well,
answering mortality, AFib.
Yeah, well, on the one hand, interventional, but just in 5 days, we will present at the American College of Cardiology. I will present an intravenous iron trial of 1,100 patients. and there will be two publications, one for the main results of the trial, but then also in Nature Medicine, the meta-analysis, updated meta-analysis of 7,200 patients with intravenous iron. That shall be very enlightening, I think.
Very good, very good. For the tone of your voice and your smile, it will be a positive study, so we'll be looking forward.
All right.
It's okay. Stefan, thank you very much. I appreciate it very much, your time and effort. And we're looking forward to have you here in Monterrey.
All right. Let's do something together.
See you.
See you.
Bueno, Stefan es
Bye. Ciao.